practicing plastic surgeon at Pondicherry, India. My topic for today is male to female conversion transgender surgery and experience of more than 100 cases in a single center trial. I'm sure everyone knows what's gender dysphoria and what's trans men. The cis females who want to get converted into males are called as trans men. The study mainly comprises of 109 patients, the majority being double incision mastectomy with free nipple grafting. And I have categorized the surgeries into mainly three categories: keyhole top surgery, periareolar top surgery, and double incision mastectomy with free nipple grafting. Now coming to how to select an appropriate surgical technique. First and foremost thing which is important is the position of the nipples. So if the position of the nipples is in central and the size of the breast is small to medium type, the patient with the grade 1 ptosis with good skin elasticity all around, or the patient who is okay with minor readjustments later on after 6 months if there is no adequate skin recoiling, we go for keyhole top surgery. So then in the cases where there is pseudotosis, there is parenchymal disposition inferiorly, and patients with grade 1 ptosis, that is at the level of IMF, the nipple at the level of IMF, and the patients who are not ready for any minor adjustments later on, we do periareolar top surgery. We remove the excess skin surrounding the areola, which might have insufficient recoil, and close it with purse drain sutures in 2 layers. And the last one, that is patients with grade 2, grade 3 ptosis, there is no choice. That is nipple below the level of IMF, there is no choice but to do double incision mastectomy with free nipple grafting. Now this is the case wherein you can see that it's a medium volume breast, the nipple is right in the center with good skin elasticity all around, and the breast is evenly distributed all around. So this is a good case for keyhole surgery. Now these are a few examples of my keyhole surgeries. You can see the breasts have some amount of parenchymal disposition, but the nipples are fairly in the center. So I have done keyhole surgery. Immediately you can see there are few inferior tires inferior to the nipple areola complex. But with time, with good exercises, chest wall exercises, there is recruitment of the pectoralis major muscle underneath, and the tires disappear. Now these are the few complications. The most common complications I have encountered with the keyhole surgery is the nipple depigmentation, which usually settles over time. And the second most important complication is the seroma formation. The seroma, both the complications can be dealt easily. And the third complication which is seen in this keyhole surgery is the inferior skin folds. The inferior skin folds, usually with time, with proper exercises, chest wall exercises, by recruitment of the underlying pectoralis major tissue, the ties usually disappear. But if anything remains, we can always correct it later on when the patient comes down for stage 2 procedure, that is hysterectomy and vaginectomy. Now this is an example of a case which is suitable for periareolar top surgery. You can see that the nipple is in the center, the breast is small size, small to medium size you can say, and there is too much of excess skin in the inferior pole. There is some amount of pseudotosis. These are the patients with low skin elasticity and usually require periareolar top surgeries. So this is how we do a periareolar top surgery. First, we remove a sizable amount of the skin. We always are cautious to underdo it rather than overdo it, because overdoing it will result in hypertrophic scar formation, scar spreading, sometimes even ulcerations. So we have to always underdo it, and we have to leave some amount of the skin. It might look excess initially, but over a period of 6 months or to 1 year, it usually recoils and gives a good result. So this is the final result, and we always keep drains in periareolar top surgeries because any underlying seroma will increase the tension at the stitch site and might cause scar spreading immediately. So the sagging, the severe sagging, grade 2, grade 3 ptotic breast, there is no option other than double incision mastectomy with free nipple grafting. These are my results of double incision mastectomy with free nipple grafting. This is the most common complication seen in Indian patients, that is hypertrophic scarring. It's still acceptable in majority of the Indian population. Now coming to the complication chart, as I have discussed, in keyhole, mainly it's the extrascaphoid seroma and nipple depigmentation. In periareolar, it is the scar spreading and hypertrophic scar formation and ulceration and adhesions in some cases. And in double incision mastectomy, it is usually the keloid. The lateral skin excess, which was there, I have encountered in initial cases, but not now. Mainly, what I have encountered is hypertrophic scarring, and sometimes getting converted to keloid if the patient has a darker skin tone. Now, what's different in the Indian population? So the main difference in the Indian population is the scar is never inconspicuous. The scar is always visible compared to the Western white race population. And then there is always more incidence of hypertrophic scarring, and there is sometimes going to keloid formation. Because of this reason, many of our patients are usually comfortable with the minor extra skin folds here and there rather than a big scar on the chest. These are some of my results of tough cases, the cases which were done redo top surgery cases, the cases which were earlier operated by other surgeons from India and outside in the neighboring countries, which was corrected by me. The nipple was regrafted, again with good results. This is the case of nipple malposition, which is nipple position is corrected again. The nipple is removed, nipple area complex is removed and reattached in the normal position. Now, in conclusion, the trans surgeries, the top surgeries are relatively straightforward surgeries, and they are the first step in gender transition. And patients usually aspire for flat chest, and they are okay with the scar unless they look little presentable, and that is why majority of the complications are very minor and can be easily corrected in multiple stages. Thank you. Thank you. For further details, you can visit my website www.pondicherrytransgendersurgeries.com, and feel free to talk to me if any queries. Thank you.